Mr. Chairman, dear colleagues, thank you very much for the invitation, the organizing committee. Now, when we are dealing... Sorry, it doesn't move. That's right. When we're dealing with decompensated patients with aortic stenosis, we have to divide into two categories. One is the truly hemodynamically compromised patient, the patient who comes down to the cath lab with low blood pressure and severely compromised. And the other category is the patients who can be potentially decompensated. The patients who come in a stable condition, but they've got risk factors and they can decompensate. Now, let's see the first category, and the most common clinical scenario is a patient with cardiogenic shock. And this is a case of an 82-year-old male with a previous history of inferior myocardial infarction 15 years ago, severe left main proximal LAD disease, blocked circumflex, blocked right coronary artery, severe aortic stenosis, and a porcelain aorta. And you can see his coronary angiography. There is ostial and distal left main disease. There is proximal LAD disease, blocked circumflex, blocked right. And you can see the porcelain aorta. And here is the appearance of his aortic valve, which is severely calcified with moderate LV function and also severe mitral regurgitation. Now, he was discussed at the heart team, and due to the comorbidities, we decided to evaluate him for PCI and TAVR in the same procedure. And by the time we were discussing all this, the patient came back with a non-STEMI, troponin positive, and he developed a full cardiogenic shock. He was intubated, a blood pressure of 80/50. He was oliguric and fully supported with inotropes. So he went down to the cath lab immediately, and we had to act very quickly. We put a couple of stents in the left main, the proximal LAD, and this was the result after stenting. And then very quickly we followed with valve deployment, and we had a very good result. And you can see here the transesophageal echocardiography. And the whole procedure lasted about an hour and a half, less than an hour and a half. The patient recovered very quickly, and he was hospitalized for 4 days. He was discharged in very good condition. The second scenario is the scenario of a patient with acutely failing aortic valve bioprosthesis, and we heard a lot about it. We know the mechanisms of valve bioprosthetic failure, wear and tear, calcification, pannus, thrombus, endocarditis, and we all know that valve-in-valve is a very efficient and quick treatment. And this is a case of a 78-year-old male who underwent an bioprosthesis AVR 3 years ago with trifecta 25mm due to severe aortic regurgitation. And he also had a mitral valve repair with Alfieri stitch due to severe mitral regurgitation. At the time, he had normal LV function. He was well, and he presented with just 8 days history of increasing breathlessness. When he came to us, he was in cardiogenic shock. He had a VF arrest. We had to shock him twice, and he had a blood pressure of 90/30 on full hemodynamic support. So we diagnosed that it was an acute valve bioprosthetic valve failure. So he was opted for an emergent TAVI, and you can see his transthoracic echocardiography. You can see the aortic regurgitation, and you can see the transesophageal severe aortic regurgitation. You can see here massive AR. And looking for the cause, because it was very, the patient didn't have any signs of endocarditis. You can see there was a wear and tear of the right coronary cusp of the trifecta valve within 2 years. So we went ahead with a new valve, and during the procedure, the blood pressure on full inotropic support was 40, so we had to be very quick, implant the valve, and we had a very good result in the end, as you can see here. And this is the blood pressure before the procedure. It's 90/30 on full inotropic support, and after the procedure, 150/70 without inotropic support. And this was the transesophageal appearance after the end of the procedure. So in conclusion, this was a bioprosthetic acute AER, which led into cardiogenic shock very quickly, and this has to be suspected and detected early, and TAVI valve is a very quick and efficacious option. And these cases, actually, these two cases illustrate the potential usefulness of primary TAVI as we do primary PCI in severe acute heart failure requiring urgent intervention. Now, let's see the potentially decompensated patients. Patients who are in a good condition, but they can decompensate during the procedure. And we all know various clinical predictors of increased risk. And from all these predictors, I think that low flow, low stroke volume index is the worst predictor. And we know that it's low flow that is independent predictor of mortality, not ejection fraction or mean aortic gradient. And we also know from early ages that TAVI is a very good treatment for these patients. And very recently, there is a new staging of aortic stenosis, not based on the aortic severity as such, but based on the extent of cardiac damage. So there are 4 stages, 5 stages. Stage 0 is just pure aortic stenosis without any damage, any other cardiac damage. Stage 1, when we have LV damage. Stage 2, when we have mitral damage, mitral regurgitation, and big LA. Stage 3, when we have tricuspid damage and pulmonary hypertension. And stage 4, when we have RV dysfunction. And the more advanced the stage is, the higher the mortality is, and also the higher the risk during the procedure. So this is a scenario of a typical potentially decompensated patient. 79 years old male with paroxysmal AFib, multiple CVAs in the past, repeated admissions with acute LVF, and moderate renal failure as well. And his echocardiogram showed moderate LV function, about 30–35%, severe aortic stenosis, low flow, and moderate to severe tricuspid regurgitation and severe pulmonary hypertension. So according to the previous staging, stage 3. So increasingly, potentially patient for decompensation. And he didn't have any coronary artery disease. He was opted for a valve, a TAVI valve, and he came down to the cath lab in a stable condition. And you can see here, it's not only the appearance of the valve, which is a heavily calcified valve, but if you see, there is a lot of LA thrombus. And despite the fact that the patient was fully anticoagulated. So that means that there was low flow. And this proved to be the case because as soon as we crossed with the valve, the pressure dropped down to 60, and we had to support him inotropically and be very quick and have a good final result in the end. And this is the appearance post-TAVI, a very good result. So the criteria for decompensation in this patient was not only the poor LV and the low flow, also the pulmonary hypertension, but the LA thrombus despite full anticoagulation. This was a criterion of low flow, and this guided to hemodynamic collapse during TAVI. Now, another scenario is a patient with multiple comorbidities, severe symptomatic aortic stenosis, high STS score, and other comorbidities, but with anticipated life expectancy of more than 1 year. And this is a case of a 79-year-old lady with previous metallic mitral valve some years ago with normal function, poor LV, ejection fraction 30–35%, severe aortic stenosis, low flow, stroke volume index less than 35, severe pulmonary hypertension, right ventricular dysfunction, and also myelodysplasia. Very high score, and according to previous staging, stage 4. And we had we put a Lotus valve in this case. We had to have a fully recapturable valve, and with a very good result. And also The LV improved considerably after the procedure, and this is the appearance of the valve, no aortic regurgitation. Now, another scenario that sometimes we have to be very careful is when the patient has got associated coronary artery disease, and we heard about it before, when we should intervene first or after the TAVI. And this is a strange case, an 83-year-old male who had PCI to circumflex and distal right coronary artery, and he developed unstable angina, and he also had moderate renal failure, and his echocardiogram showed an inferior hypokinesis and also severe aortic stenosis with a valve area of 0.5. So his catheterization showed proximal LAD, moderate severe proximal LAD disease, proximal RCA disease that we thought it was the cause of his unstable symptoms, patent distal stent in the right coronary artery and patent circumflex stent. Because it was quite unstable, we decided to perform PCI and TAVI on the same occasion. And when he came down, he had ECG changes of inferior ischemia. So you can see the valve here and the aortogram. So this is the right coronary artery before and after putting a stent. And this was the proximal LAD, moderate plus lesion. We put a stent on the proximal LAD. And during the PCI, he didn't have a lot of ischemia. Very mild ischemia during the RCA PCI, but no hemodynamic compromise. Then we went on with the TAVI at the same procedure with a very good final result. And during TAVI, he developed severe inferior ischemia with severe hemodynamic compromise and blood pressure of 60. So perhaps the unstable ischemia was more due to the aortic stenosis rather than the right coronary artery stenosis. And this was the appearance after TAVI. His LV improved considerably. And the last scenario is when the patient has got multivalvular disease. This is a potentially decompensated patient as well. So this is a case of an 80-year-old gentleman who had a bypass operation some years ago, and he presented with severe breathlessness. And his echocardiogram showed inferior hypokinesis with moderate LV function, severe aortic stenosis, valve area 0.64, and also severe ischemic mitral regurgitation with severe pulmonary hypertension. His coronary angiogram showed patent grafts and no severe stenosis in the right coronary artery, which was not grafted before. And he was stage 3 according to previous classification. We opted for TAVI and then decide what to do with the mitral regurgitation after TAVI. And you can see here severe aortic stenosis and the severe ischemic MR with hypokinesis of the posterior leaflet and loss of coaptation. And you can see the mitral regurgitation jet. So he had the TAVI, he had an Evolute R with a very good final result. But the patient remained heavily symptomatic and he couldn't recover from his failure. So you can see the result of the TAVI, but you can see that the mitral regurgitation is possibly a bit worse than it was. So he had to come down to the cath lab very soon after the first procedure and receive 2 mitral clips with a very good result. And this was the final appearance. And this was the angiographic appearance. So dealing with the decompensated patients with aortic stenosis, if they are hemodynamically compromised, we have to treat urgently. If they are potentially decompensated, we have to treat carefully. Thank you very much.
Thank you very much, Dr. Dardas. I think that we have